Greetings to everyone. On behalf of the Asian Development Bank, I would like to warmly welcome you to today's 21st Secure webinar on leveraging insurance and innovative financing for non-communicable diseases in South and Southeast Asia. We're very glad that you're able to join us virtually, and we appreciate you taking the time to be here. This webinar is jointly organized by the Secure team, as well as the team from the technical assistance on strengthening primary care for the management of non-communicable diseases. The webinar is also part of ADB's commitment to share innovation and best practices in the region. Non-communicable diseases present a significant challenge to public health systems and the economy. The impact of these conditions is particularly pronounced in Asia and the Pacific and on the most vulnerable. Yet, financing for these conditions, as we're all aware, remains insufficient. The webinar will explore experiences from South and Southeast Asia on leveraging national health insurance schemes and some innovative financing mechanisms to address non-communicable diseases. It will highlight lessons learned and examine the critical barriers and enabling factors necessary for the effective management of these conditions. The webinar brings today a distinguished group of experts to explore how these mechanisms can help address non-communicable diseases in real-world settings. We highly encourage you to engage effectively during the webinar by asking questions, sharing your insights, and so on. Thank you for joining us today, and we hope you will leave today's webinar with some inspiration and information on non-communicable diseases. Thank you. Bye-bye.
Hi. Good afternoon, good morning, good evening, wherever you are. I'm very happy to welcome you to this webinar. And as Alexo mentioned, this is something which we are trying to work and share with you all these very important topics. And this is one of the important topics which we are trying to work with you. So the role of insurance in NCD is very important. And for example, we have seen that in many countries, wherever NCDs are being covered under health insurance, the utilization has been found to be very high. And as we can see overall globally also, as countries are getting this dual burden of disease, that in addition to communicable diseases, non-communicable diseases are also becoming high and high. We see that they have to be treated. And one of the important ways in which they are being covered is through health insurance and health financing programs across countries. In this regard, I think we have two very excellent examples coming from Asia, from Indonesia and India, where in both the countries, there are very innovative health insurance schemes which are covering various kind of NCDs, and they have shown excellent results. So we have speakers from both the countries, and we will be very happy that if they are able to share their experience with the audience and also with us, and we can see actually why these schemes were structured in the way they have been structured, and also how they are able to tackle the issue of NCD. So we have Dr. Pankaj Arora from India. We'll start with him. Dr. Arora is working with National Health Authority as director in the division which looks after health insurance, which looks after health packages, which looks after pricing and all these things. And he is a very experienced person. He's not only a theoretician, but actually he I think he still is a practicing doctor and a surgeon, and he has done a lot of work in the field, but at the same time, he has a very strong academic credential. He has studied in London School. Recently, he's finished in MPH. So I think that I'm very happy that he's able to be here with us and share the experience of National Health Insurance Scheme of India called Pradhan Mantri Jan Arogya Yojana, PMJ in short. So over to you, Dr. Arora. Thank you.
Thank you, Dr. Nishant. Very warm welcome from India, from the National Health Authority, Minister of Health and Family Welfare. I'm really thankful to ADB for giving me this opportunity and to create such environment where we can discuss about these things like NCDs and other problems which are there to be discussed and to be taken forward and policies to be made and cross learnings to be done. Is my screen visible right now?
Yes, you just need to put in full screen.
Right. Sir. Just a second, sir. Is it in full screen now or not?
Not yet. You have to go to the presentation mode, I think.
I'm doing it. Just a second.
Yeah.
All
Fine.
right. So we'll discuss about not only the Ayushman Bharat, but some other programs also which are doing, but especially I will kind of concentrate on what Ayushman Bharat PMJ has done and how is leverage insurance and innovative financing to deal with the national non-communicable diseases from through its flagship program. So, India has been evolving strategies to address the rising burden of the non-communicable diseases through several programs, especially the Ayushman Bharat PMJ and NCDs kind of is not a problem in India only. It's globally there, and 70% of global deaths and 70% of deaths in the Asia Pacific region are through by NCDs. And in India, we are not behind, but because we have a higher communicable disease, that's also so the NCDs are accounting for 63% of that. It really is a high number of premature mortality, which is also there among individuals between 30 to 70, which is nearly 23% of the deaths among these. This growing burden not only impacts the population health, but also imposes a heavy economic toll, as you can see in my slide, with the projected loss now will be doubling for India in 2030 up to 472 billion from dollars, which was earlier 237 billion calculated in 2018. And this is there's a lot of direct and indirect cost involved, which leads to high out-of-pocket expenditure and catastrophic health spending among the population and citizens in India. My slide is not moving. This yeah. Uh, burden in India of NCDs is can be further seen through the prevalence data which I've shown, showing high number of people affected with diabetes, hypertension, obesity, and cancer, with the high uh, total dailies caused by NCDs. It's nearly the same. At 60% is globally, and India is not behind, and it's like 58% on that. And there's a huge economic impact due to that. In response to this, India has adopted a multi-pronged strategy. One of them being the Ayushman Bharat PMJ, but yeah, it's really done in a very good way through the National Program for Prevention and Control of NCDs and establishing further 1.15 million Ayushman Arogya Mandirs, which provide comprehensive primary healthcare to our beneficiaries and population. And also, then it has been supplemented for the secondary and tertiary care through the Pradhan Mantri Jan Arogya Yojana, which was launched in 2018, September, nearly 6 years ago, and it has given a very good results. And there is a complementary initiative, including the Ayushman Bharat Digital Mission and eSanjeevani, which is a telemedicine platform which gives kind of the consultations to far off people who are not able to reach the hospitals and cannot get the specialist care. So that has been developed, and there's a multi sectoral action also targeting key behavior risks like tobacco and alcohol use and use of having unhealthy diet in the in the diets people take in India. And not only uh, uh, PMJ has given good coverage in financial protection. It is actually uh, also working. It's a stepping stone towards the universal health coverage. And the SDG 3.8, which we want to achieve, and leaving no one behind, and giving treatments to all of these people, and to provide to the poor and vulnerable their unmet healthcare needs by giving services in the areas where they are, and quality service, not only the accessibility but quality services. We have gone kind of to increase those, that WHO cube, which is and kind of we are extending by increasing the population we are covering. We started with 500 million, increased it to 550. Now we have increased it more by 660 million by adding the elderly and giving them free healthcare in irrespective of their financial status, as well as now we are going further to include other peoples by converging different kind of scheme with through participating with different ministries, including transgender people, giving them free healthcare, the people, the persons which are gig platform workers, the people who are having road traffic accident, giving them a scheme through cashless scheme for road traffic accidents, and further enhancing the rack pickers and to the sewage workers, and building and construction workers, and so on and so forth. This is basically to reduce the catastrophic expenditure in these poor and vulnerable population, and stopping them to go into the poverty trap. And just a brief to the people who have might not know about Ayushman Bharat PMJ scheme. We give a cover of zero point 0.5 million Indian rupees per family per year, which is recouped every year. It's a family floater, and it covers secondary and tertiary healthcare. And NCDs are a major focus area in that, with several specialties being covered and several packages being made available for the NCDs. And it's completely paperless and cashless scheme. Patient has to pay nothing, and includes all the stay, the food, everything of the patient there. And there's no cap on the family size or age and gender. And the very good feature of this scheme is we cover everything from the first day. So any beneficiary who is kind of getting enrolled in the scheme is having all his or her pre-existing condition covered from day one. And luckily we have done the public-private partnership in this, and there are 30,000 plus hospitals which have been empaneled, and out of them, nearly 14,000 are private sector hospitals, which is a big achievement, and it has really changed the way people look at the healthcare given by the government as such. There are different kind of implementation modes being used. Uh, Given to the insurance companies, and insurance company managing the scheme in different states, because India being a federal structure, all states do it differently. And there's a trust mode in which the state does the payment, and there's a mixed mode in which the first part of the nearly 1 or 1.5 lakh of the 5 lakh is given by the insurance, and rest has been is taken care by the state. It is these packages which I was talking about are nearly 2003, which are including 1961 primary packages and 42 add-on packages, which are spread over 27 specialties. One of them being the unspecified packages. This is just a brief what specialties we are covering. We started with these 25 specialties in HP 1.0, increased one more specialty of infectious disease, and then also included all made organ and tissue trauma as different specialty, but it is covered under it is what is it covered under different specialties where the organs are there. And then we also added palliative care recently. And if we don't have any packages for surgery, which are not being included, we allow the state to book it under the unspecified surgical package. And also, if they need high-end investigation, and high-end drugs, which are there, they can book it as an add-on package to any medical package which is there. Uh, We have covered the NCDs diagnostics also now through the add-on packages, as I told, with high investigations, the treatments and surgeries through the evidence-based health benefit packages. The major specialties which are being booked, which book NCDs are cardiology and cardiac surgery, the cancer. Is being covered through medical radiation, surgical oncology. The dialysis is being covered. Transplants are there. All the diabetic complications are being covered. The primary diabetic care is taken care by the National Health Mission. But if there is any complication to diabetes, being nephropathy, being retinopathy, all are being covered. And we give the palliative care for cancer, all the surgical management for the NCDs which are required, as well as the follow-up packages we have created in the patients who are being treated for cardiovascular diseases. They can be followed up through a specialized package. So, and NCD related claims really kind of count for a good amount of claims. We have been paying nearly 30-40% of that. And PMJ has had a huge impact on the access and the utilization of healthcare in India. And several studies have shown that there's increased health access, especially for dialysis in different parts of India. And the utilization has significantly increased for these healthcare services. The financial protection is definitely there, because nearly 24% decrease was found in the catastrophic health expenditure above 10% in a recent study, and it definitely reduces inequalities. A recent paper in Lancet has also shown how PMJ has helped and had a positive impact on reducing the treatment delays in cancer care, with a significant decrease in the out-of-pocket expenditure under this AVPMJ scheme for the beneficiaries who are taking treatment under the panel hospital. And especially for the poorest quintile, the financial protection has significantly increased. India has also been trying to increase its expenditure, government health expenditure, as a part of the total health expenditure we are doing, and the out-of-pocket expenditure is decreasing now a little slowly but steadily, and we have now come to 39.4% of the total health expenditure, and we are trying to go more further for the same. Definitely, there is no scheme which is there without any challenges, and as I told, there's everything like I'll summarize that there is a continuum of care. There is a primary care being given through the CHCs, the health center, the primary healthcare units. There is a secondary care given through the Ayushman Bharat PMJ public sector hospitals. There is a ABDM which is helping us to improve the things, and all things are happening. But still, there is a challenge of continuum of care, and we need to have improve that referral system and follow-up mechanism both up and down, and that will improve the final outcomes actually for the NCDs. ABPMJ being inpatient focused, it is actually not giving that long-term OPD care, so we have to depend on the National Health Mission for that. And there is a duplication with the vertical NCD programs being made for dialysis, made for other diseases which are working in silos, and we are trying to do and collaborate through ABDM and creating a interoperable digital health system which talks to which can talk to each other. But still, there is again a challenge of poor adoption in these initiatives. Also, there is a very poor screening, low screening rate for cancers, including breast and cervical cancer. It is only 0.9%. As well as poor awareness among the beneficiaries leads to less utilization. These things we need to improve, and that's what government is looking into. And also the regional disparities and socioeconomic barriers. Poor having the different kind of diseases, increased tobacco and use is there in them. The rich having diabetes and more prone to cancer. Finally, the poor health seeking behavior is also a challenge for us. And what has worked well for us is there is a strong political will, and there's a commitment to achieve the universal health coverage. convergence of schemes is being done by the government. NCDs are being taken care of not only by PMJ but other programs. Integrating secondary and tertiary healthcare is one of the things in which NCDs have been given the primary, one of the big seat on the table, and we have the data which we use for improving the transparency through the anti-fraud triggers and other feedback loops. But definitely, as I told, the vertical fragmentation, the problem awareness, and about the continuum of care, and rather integrated care, which I said should be available in both direction. We need a lot of capacity building for these things, and the doctors need to know the primary healthcare level people need to know how to refer and all, and we need to expand maybe PMJ also to include the OPD services and increase the adoption through the digital mission and more private sector engagement and the financing reforms are needed. The government has a vision to finally have health for all in India and expand its coverage through Ayushman Bharat PMJ and bridge that gap and have full continuum of care. And we are doing a very good work in creating health benefit packages, especially for NCDs through strategic purchasing and collective bargaining. And we are kind of also have developed an amazing what do you say group of standard treatment guidelines which help them not only get treatment but get quality treatment for these NCDs. Private sector has been engaged, as I told, especially in the underserved area where we don't have government facilities. These people have come up and helped us to give the healthcare, and we are increasing our outreach through the IC activities and making the people aware about these facilities available, especially for the vulnerable, elderlies, low income groups, and other marginalized people. And we'll definitely love to reach that one-third reduction in the premature NCD mortality by 2030. In the end, it's I think I've taken more than the time allotted to me, but I'll summarize that NCDs are a really major burden and economic threat, and thankfully we are discussing it today. And hope this meeting results in some changes and I learn more and better things for my country. Our scheme offers a strong platform for especially for inpatient care in NCD and decreasing the out-of-pocket expenditure for these poor and vulnerable. And the main challenge which remains the integration continuity of the care. And we need to have more comprehensive NCD management, including the follow-up and the OPD care, which needs to be done. And we are doing a bit from converging the schemes of all the schemes on a single platform so that there's deduplication and there's no wastage of resources at national level, and we can cater to more people. And the government is in a vision of giving this facilities to more and more people, recent being gig workers and road traffic victims and transgender. And I'll thank you again for giving me this opportunity to tell what we are doing in India and how, and we are ready to help in any which way any country wants to learn about it. Otherwise, we'll be happy to learn also from the other countries too. Thank you. Thank you.
Thanks. Thanks, Pankaj. And I think this was a short presentation because of lack of time, but I think it's an excellent example how India is trying to use the insurance scheme not only to tackle NCDs, but also to bring these various fragmented things together. And I think this is a very timely reminder that it needs to be done in a strategic way by the country. And I think India is doing it. And I'm also very happy that you are very open about sharing the challenges also, that what are the challenges which are being faced, so that those challenges, some solutions could be found, some solutions could be learned from others. So there are these various ways to do it. And in this regard, I think when I talk about fragmentation, then when I come to the next presentation, that makes it very nice because Indonesia is one of the very good examples where a country was able to bring these various fragmented big insurance schemes together under one umbrella, under one scheme, as part of one scheme, merged it. Even Thailand has not been able to do it, what Indonesia did in terms of merging many various schemes together. So Indonesia is an excellent example of sharing about the health insurance part, what they are doing in terms of also, and they have a very comprehensive package, right from primary care to tertiary care. And in this regard, also they're covering NCDs in very well. And I'm very happy that we have an excellent presenter coming and sharing with us his experience from Indonesia. So Arif has worked as assistant deputy research in BPJS Kesehatan, and this is an organization which is managing the national health insurance program in Indonesia, and so that is where, and I think that he is there in BP with this program, and before that with the previous program which was there ASKES. So he's there since more than 15 years. So he brings with himself a very rich experience of working in the program, and he's this is MPH from US Atlanta. He has an excellent experience, and he brings the researcher bent of mind also. So he does not only will show the data, he'll also say the story behind the data. So I'm very happy that Arif is there. Over to you, Arif. Thank you.
Thank you, Dr. Nisan, for the time and opportunity. Good afternoon, everyone. I hope you enjoying this webinar and got all of the insight from all of the countries about how we tackle, how we manage the non-communicable diseases in Indonesia and in each country. So allow me to present the material. I'm here on behalf of Mr. Mahlir Ruby, our Director of Planning and Development. So couple of slides from Indonesia. It will be depicted how our efforts, how our response to tackle non-communicable diseases. So this is our Director of Planning and Development, Mr. Mahil Ruby. At this time, he cannot join because he has another agenda with the coordinating minister. So let me have an overview for all of you about the National Social Health Insurance in Indonesia. So based on this graphs, you will see the three pillars of national health insurance, which is all we may know about: strategic purchasing, revenue collection, and risk pooling. So if you can see here on the right side, the members will pay some premium because our scheme is not tax-based. So we need contribution from the members. The contribution will be vary because based on what is the segmentation of the members. So for the poor, of course, the government will pay the premium, the contribution, and also for the formal employee, there will be 5% from their wages, which is 4% paid by themselves, and I'm sorry, 1% pay from themselves and 4% from their employer. And also we have the non-formal employee that they will pay by the dedicated contribution, which is it's depend on which class that they are selected. There we have three classes of the inpatient rooms in hospital, and they can choose which fit with them. And right after the members got register in our scheme, they will have a benefit package from from us. So it depends. We have like two level of care. The first one is primary health care, of course, and then the referral health care. We pay the primary health care with the capitation and also non-capitation. As we may all know, the capitation will be some effective. It's effective. It's cost effective in Indonesia because it gives the opportunity for the primary care to provide better care and how they can save the money from the capitation. And for the referral healthcare, we pay with the case-based group. We call it CVDs, Indonesian case-based group. And of course, there's some of them, and it's a CVDs. And this one is some payment scheme that really used by Indonesian and health facility that contracted with BPJS Kesehatan. So what's the position of BPJS Kesehatan in Indonesia? So the BPJS Kesehatan, the NHI, the National Health Insurance in Indonesia, we are not for profit legal entity. When we have we are in the single payer, and the position of our institution is directly under the president of Indonesia. And of course, I will tell you about what is the membership of our scheme. Per 1st of May in 2025, we reached 98.2% of the total population of Indonesia. So our member this month is 279,800 something. That is covered 98%. Well, the 1%, about 1%, the unregistered members or unregistered population, maybe this is our one of our issue, because it's kind of there's a lot of challenge to get the 100%, because some political issue and also the social issue and other else. So as we can see here in how many is our the healthcare facilities for the primary healthcare. If you can see here in the graph, from 2014 until 2025, maybe it's about 11 years, there's a trend in increasing of the primary healthcare. In 2014, when this program developed for the first time, our primary healthcare that consists of the community health center and also private clinics, private GP, private general practitioner, and also dentist, military clinics, police clinic, and type B hospital. We have 18,000 in 2014, and it's kept increasing year by year until 2025. We have 23,443. And for the secondary healthcare, or for the hospital, in 2025, there are 3,132 of the hospital. It includes the private hospital. So most of them is a private hospital, about 2,056 private hospital, and the rest of it is a state hospital, and also for the local government owned hospital. So this hospital and all of the primary healthcare is spread out all around Indonesia. That consists of 17,000 islands actually, and 34 provinces. So talk about the out-of-pocket in Indonesia and how much the contribution of the national health insurance in Indonesia health spending. So if I can see here, there's the trend from 2014 until 2023 that show us how the contribution of if you can see the red one, that is the social health insurance that we are managed. So if you see in 2014, the red part is only 14.7%, which is still a little portion of the total health spending, but year by year it keep increasing until 2023. The social health insurance portion in the health spending is increasing to 27.6%. I think this is the one of the how the nation supports the health spending. And also we can see the out-of-pocket is keep going decreasing, because most of the population is including and registered to the national health insurance. And I can also say that the public health spending factors, there's some factors that like a double burden, infectious disease, non-communicable disease, malnutrition, and also we have a challenge in geographic burden. So we are an archipelagic country. So when we travel to another island and then it's far from the capital of Jakarta, Of course, the access for the hospital is really rare in, like, let's say for the east part of Indonesia is really different with the west part of Indonesia, which is the east part of Indonesia, or eastern Indonesia, is lack of the hospital, lack of a primary care, and also the cost for let's say for the drugs and for the medicine is really high, because the geographic burden. And also another issue is the political burden, so decentralization and government commitment. That is two of the issue that I think not only in Indonesia, in every country, the political burden is also the problem. And of course the social burden, health seeking behavior, and local culture. This is the healthcare service utilization. If you can see here in 2014, when this program started for the first time, there is a 252,000 visits per day, and or 92.3 million visits per year. But in 2024, each day there are 1.9 million visits. This visit is happen in the primary care, both in primary care and the hospital. It could be outpatient or inpatient in the hospital. So this increasing show that the access that gives from this program is very enormous for the population. And if you can see in the left side, that is our healthcare expenditure. And up to 2024, we spend 175.07 trillion, or it's about 10.26 billion US dollar. So it's keep increasing year by year. And in the right side, I tell you about the chronic, the catastrophic expenditure. It's took part about 24 until 31% of our total spending. So the total of catastrophic expenditure from 2014 to 2024 is no less than 235 trillion, or about 13.78 billion US dollar. Most of the catastrophic expenditure occur in the heart disease. If you can see here, the red in the pie chart, the red one is the heart diseases. So it could be the surgery in heart disease, and also the heart failure, and all of it. And the 7.9% is in the cancer, and 15% for the stroke, and the another big part is from the kidney failure, the orange part. So this one is the chronic disease patient. The patient with the chronic diseases. I think this is show us how big the prevalence of the chronic disease in our scheme. So if you can see here in the bar graph in the left side, there's asthma, diabetes, hypertension, heart disease, also schizophrenia, stroke, cancer, epilepsy, kidney failure, and also the chronic obstructive pulmonary disease. If you can see each year, so the graph is show us the data from 2022, 2023, and 2024. So it's a 3 years data. So each year it keeps increasing. It keeps increasing. Maybe if you can see is, for example, for the heart disease, the average growth per year is 19%. And for the hypertension, also 22%. For the diabetes mellitus, the increasing year per year is 20%. So this is the data from our data claim. So it keep increasing. So this is show us that this is become the non-communicable disease, or the chronic disease becomes a big challenge for Indonesia. And the right side graph, it shows us about the trends in healthcare expenditure versus the chronic disease expenditure in referral care facilities. So the orange part, that is the non-chronic diseases, and the blue one is the chronic diseases. So, this is the chronic disease patient who receive service from JKN continue to increase every year, and the highest average annual increase are hypertension. It's average of 0.9 million, and followed by diabetes and heart disease. So if this condition is not managed optimally, it can lead to financial instability. In long term, it will have an impact on the deficit. So maybe deficit is in the social health insurance scheme is not it's common thing. Yeah. So in Indonesia also we face the same issue, deficit. So we are very put concern about the financial sustainability that bring us to have a some of response to tackle the healthcare spending, especially from non-communicable diseases. And this data show us about the chronic disease risk factor and spreading out in Indonesia, how many the chronic disease cases per 1,000 population. So if you can see here, the eastern part in Indonesia, let's say for the Papua, is really rare, the chronic disease cases, compared to the western part of Indonesia that is really high in the prevalence of the chronic disease. So chronic disease factor, risk factor, as we may know, the lack of physical activity in Indonesia, there were 33% of the lack of physical activity, and also the unhealthy diet. Smoking, almost 30% of the population is active smokers. And overweight also, 21.8% population is in the overweight status of the BMI. This graphs show us about the how the percentage about in each type of diseases, in the chronic diseases. If you can see here, the heart disease patient, the lower graph is, let's say it's really balanced between male and female. Also for the kidney failure, it's quite balanced. But if we talk about cancer, it happens more in female. And also the diabetes, it happens more in female. Stroke also, and then the hypertension patient also have a higher prevalence for the female. So how we respond in managing these cases? So if you can see the table here, the type of complication, we know that hypertension and diabetes are the mother of diseases. So we are focusing on those two diseases. Type of complication for that leads to heart disease and hypertension and stroke is quite high in Indonesia. The prevalence in diabetes patient is 30%, and then the hypertension caused by diabetes also 66%, and for the stroke 11%. And this one is lead us to the more than 49.3 trillion rupiah were spent in 2024 to treat diabetes, hypertension, and stroke, kidney failure, and heart diseases. So this is all of the diseases that we are put concern. So this lead us to the hypertension and diabetes prevention program. So this is some of our efforts: the health promotion, health screening, chronic disease treatment, refer back program, disease management program, or we call it PROANIS. All of this initiative is like combination. All of these 5 combination made help us to control the non-communicable diseases or the chronic diseases. The health promotion, of course, we educate and monitor for the members who have not shown risk at risk, or because we have the health screening through our mobile application. So all of the participant is easily to use it to know how their status of health. So the diabetes mellitus screening by blood glucose, hypertension screening by blood pressure, and stroke heart disease also by blood pressure. So right after the health screening from the app, and they can go to the primary care with free, because we pay the primary care with the capitation. And also we have the chronic disease treatment, diabetes and hypertension medication every month, both in primary care and hospital care. And also refer back program. I don't know if you are familiar with this kind of terms, because in Indonesia, we do implement the referral system. So as a gatekeeper in primary care, the patient cannot go to the hospital directly. They should be go to the primary care first, and then if there's a medical advice to go to the hospital, they will be go to the hospital. But the refer back is the how the hospital give back or refer back to the primary care. So the members with control condition for diabetes and hypertension in hospital may proceed the medication in primary care. So this is one of our, this is also how we decrease the spending in hospital. And the last thing is the disease management program, or PROLANIS. PROLANIS aims to stabilize diabetes mellitus and hypertension members' clinical condition. So we control our participant blood glucose examination, HbA1c, cholesterol examination, physical activity, and personal health promotion. So in the PROLANIS, we have some groups in each of the primary care. We ask the primary care to make some PROLANIS group of members. So maybe it consists like 30 to 50% that have already a diabetes and hypertension, and we ask the primary care to manage, to give education, to check the blood glucose, the blood pressure, and so on. So this is some of our efforts. This is the promotive preventive service in Jack and scheme. I think maybe I will not focus in the slide because the time is limited. Yeah, that I continue about the PROLANIS. So the PROLANIS I talked before, it's about the health service system with an integrated proactive approach involving participant health facilities and BPJS in the framework of healthcare for participants with chronic diseases, especially for the type 2 diabetes and hypertension, because, you know, as I mentioned before, these two diseases is the mother of disease. So once we can control this diseases, maybe hopefully all another disease will be decreasing also. So what is the goal for in PROLANIS? The goal is encouraging participant independence, increasing participant health status, increasing participant satisfaction, and controlling health service costs in the long term. So that is the long-term goal is our objective. The PROLANIS evaluation per December 2024, we already reached about 600,000 members of PROLANIS. For the diabetes and the PROLANIS hypertension, we have reached 1 million from the total. So in the PROLANIS activity, there's health consultation, medicine service, lab tests, and education and physical activities.
I think
So this
I
one
need to now close because it's getting, we have to have other speakers. Thank you.
So sorry. Okay, I'll skip, and yeah, how the PROLANIS or promotion of disease management program will be control the clinical outcomes, because this is one of the indicators. So if the primary care has a bad management in PROLANIS, that will affect our day payment from us, because we have the KBK performance indicator. So there's the performance, the pay performance. This is about the digital innovation, not only the financial or that program. We also develop digital innovation. And okay, so the key takeaways, maybe this my last slide. So 4 things that we need to would concern in strengthening the role of primary care, because the gatekeeper is very important, and then also the improving the PROLANIS or refer back program to control the cost in hospital. And the third one is participant engagement, how we increase their awareness, compliance, utilize digital health tools. And the last one is the cross-sector collaboration, of course, harmonized policies between multi-sector, integrate health programs with local government initiative, and of course, the leverage digital platform. Okay, I think that's for me, Dr. Nisan. Sorry for the time. Thank you.
Thanks, Arif, and thanks for a very nice presentation, because it shows how important is the primary care, because that's where everything goes from. So I think if you have a strong primary care system, it's much easier to actually control things overall. And I'm sure that the slides will be shared with the participants, so you can always get more details. People who are attending can see more details from the presentation. But I think some very excellent things are being done by Indonesia in this regard. Now I thought initially I'll have a couple of questions, but now since we are already behind time, I'll request my colleague Vas to take over from here for the next part. Thank you.
Thank you very much, Nishan, and also thank you for the two previous speakers, which really set the tone of what are the government's experience. So my name is Pasuntara Yang Priksawan, and I'm co-leading the Technical Regional Assistance on Primary Healthcare and Non-Communicable Diseases. In this session, we will have two distinguished speakers. The first presentation will be focusing on the landscape analysis of innovation and innovative ways of doing a financing for NCDs. In this session, we have Dr. Priyanka Bajaj, and she is a specialist in health technology innovation at PATH. So we have been working with PATH for the last year, working in different aspects. And in this working paper, Dr. Priyanka would show some case studies with the overall the findings that we have. Dr. Priyanka, the floor is yours. Thank you.
Thank you, Dr. Vas. I'll just project my screen. So a very warm greetings to everyone. Like Dr. Vas mentioned, I will be presenting findings from an upcoming working paper that PATH has very closely worked with ADB, and this talks about innovative financing for NCDs and Asia Pacific. In the interest of time, I will very quickly just apprise about PATH. We are an international non-profit, and we work across 70 plus countries around the world in the different domains that cover largely digital devices, diagnostics, vaccines, health system strengthening, and the gaps that needs to be leapfrogged. A lot of work through technologies and innovations in health system strengthening. Very briefly about the overview of NCDs and particularly the financing challenges that are being faced in the domain. And we deliberately have kept the focus on Asia Pacific because you see these numbers. These numbers show data from 2021 that had mortality levels associated with 43 million people, and 18 million of these occurred in the ages of 30 to 70, which means premature mortality, a very significant global cost associated with NCDs, and then attribution of 60 to reaching almost 90% in the overall mortality in Southeast Asia and Western Pacific, and then out of this, a significant proportion towards premature mortality. Now, what are the reasons behind this and how the health system's response varies across the different countries in the Asia-Pacific region? So there are certain finer nuances to these aspects that I am speaking today, and you will find more information when this working paper comes out, and we'll be very happy to share when this is published. But very top level inferences that you can draw is, one is country economies make a lot of difference. So the high income countries relatively have a better awareness towards the danger and early screening and provisions for early detection and management, but they're also able to financially also better manage these components. There is certainly a demographic transition that we are seeing, wherein the number of people over the age of 60 are expected to rise to 1.3 billion by 2050. And there is a direct indirect correlation to the rising trends towards NCDs. And the last but not the least is the socioeconomic transition, particularly urbanization and dietary pattern and lifestyle changes that we are seeing, which are mostly leading towards the lifestyle associated diseases. Now, there are certainly challenges in NCD care And we all know that there is a sustainable development goal. The target 3.4 under the SDG 3 aims to reduce NCD related premature mortality by 1/3 by between 2015 and 2030. It is a very ambitious target. But what are the major challenges in the care? One is by the very virtue of NCDs, which differs in its clinical and care pathways from infectious diseases and maternal newborn child health. This is particularly relevant in the context of primary healthcare, because primary healthcare and health systems at that level were initially designed towards dealing with infectious diseases and MCH care. There is a high out-of-pocket expenditure, and this is in most cases a recurring expenditure because of the chronic nature of the disease. The cost is not just to the individuals, but also to the health systems and countries. There are gaps in the quality of care, which may be attributed to the infrastructural gaps, to the healthcare worker capacity, or the provisions for medical products or diagnostics or screening technologies that are available. While we say a lot of these gaps can be bridged through access to digital technologies, maybe telemedicines or monitoring, remote monitoring, management. However, the access to digital itself is not equitable across all the regions that we see, and even within the region, disparities are there. If you look at the right side of this slide, these challenges are also reflected in the challenges in NCD financing, and vice versa are reflected back towards the challenges in the care. Certain additional players come into play when we talk about challenges in financing, which also include limited private sector investment, or there are governance and accountability gaps, and there are always competing priorities, and the overall expenditure towards NCDs is disproportionately low. You can see these numbers, not very great as of now, but why do we need financing for NCDs? Course, to bridge the funding gap, but these funding gaps also translate to the accessibility to care, to the quality of services, and it reduces the financial burdens on individuals and systems. So to provide safe, effective, quality assured care is where we need financing. And there comes in a need for innovative financing, because the conventional models so far have not been able to bridge the gaps that were intended to in a certain way. We have articulated 3 buckets under which these financing models can be categorized. And for NCDs, these make sense. The government-led model, which primarily are towards access. Private sector models are primarily towards mobilizing investment and expertise from the private sector. And then these innovative mechanisms, which are novel approaches, could be performance-based or could be promotion-based, or it could be a blending of different actors with their financial component, but also their capacity component. In terms of looking at innovative financing and its application in the health sector, the study that we have done, and this is being more detailed in the working paper, we've used, we've tried to articulate the bigger picture of innovative financing in a layered framework, where in the overall approach, it looks at the high-level strategy for mobilizing the capital in new and more effective ways. Then how this approach is followed is through a structural arrangement of models that operationalize it, so that becomes the mechanism. Now, within that mechanism, you use different features and devices and tools to solve a specific issue. And then these specific financial products are where you define your different instruments like social impact bonds, development impact bonds, equity, debt financing, and so on and so forth. We have also classified the innovative financing for health under different types. So type 1, on the right side, you see a table. So type 1 is, it's increasing the source for additional funding. And it's more like a resource generation. Whereas type 2, we have defined as a process innovation, where you make better use of the existing resources. And in a hybrid approach is where we define type 3, which uses both sources of additional funds and better use of the additional resources. And it looks at the entire continuum of the NCDs from preventive to a curative approach. With relevance to health and with relevance to NCDs, there are 4 prominent financing mechanisms that have been detailed out. These are impact investment, which creates a significant social impact while also offering a potential financial return. Result-based financing or performance-based financing, which is sort of incentivizing the payment based on the results. So there is a component of accountability that also comes into play. Public-private partnerships are primarily collaborative engagements, which are to design, finance, construct, and manage public projects or services. The risks and rewards are shared between private and public actors, and the public sector is important to do the oversight to ensure the public interest. And then comes blended financing, which brings the development fund, it brings the private investment together. It also brings in the capacities of the two together. There are certain concepts that apply towards blended financing. The first 3, as in concessionality, wherein you are very conservative in the return on investment from the private sector, additionality of the 2 sectors that bringing in the financing, and then appropriately leveraging these. Whereas sustainability and impact is the overall objective of blended financing. And when you do this in a measurable way, that makes blended financing also distinct from the other mechanisms of innovative financing. There's also a correlation that we can draw between these different types of financing and how they overlap. And if you see at the very core, in the overlap of all 3 of these is where blending financing sort of sits. So it also includes component of technical assistance, some advanced market commitments, first loss capital, other innovative instruments. Now, in bringing this down to the specifics of global health, when we talk about innovative financing, and when we started to speak about innovative financing for health, we saw some global organizations taking a lead on it, especially Gavi, when it brought together public-private partnerships and advanced market commitments for immunization of children, and then GFATM, which is a partnership of Global Fund for AIDS, TB, and malaria control. These were very prominent initial examples, but then you need to separate organization or institute from the design and implementation of funds. And that's where it was very important to define innovative financing. And per se, the definition says that non-traditional application of official development assistance or joint public-private mechanisms and flows that either support fundraising by tapping new resources or deliver financial solutions to development problems on the ground. So that's where the distinction needs to be very clear, and we've tried our best to do that in the working paper. The analysis also looks at 81 initiatives, 79 of these particularly from the health sector, and 2 additional because the very good correlation can be drawn from these for the health sector. These are further classified into international, national, and subnational levels. And then the 3 types that I had mentioned earlier have also been defined with examples relevant to the types, and also a lot of examples that have been tried and been successful in the Asia-Pacific geographies. Just as a very cursory view to the audience, we can look at these 3 in the subsequent slides. The type 1 is primarily an innovation that relates only to additional funding sources. Now, non-traditional revenue models like crowdfunding, voluntary donations, all of these are part of it. Sin taxes and public health taxes are also a type of type 1 innovation, unless they are earmarked for health. And there are different provisions that can also make these kind of taxes under a type 3 innovation, which we'll come to later. And then traditional forms of ODA without a performance-related conditions also are classified as type 1, but we are seeing a decreasing trend now because donors are also increasingly interested in funding for impact and performance. In the type 2 innovations, you look at innovations in the usage of funds. So these are process innovations. They involve reallocating of existing funds to prioritize health promotions, NCD interventions, screening, detection, all of these. Some great examples are when Global Fund integrated diabetes care into their HIV/TB program, the WHO best buys for NCDs and control, and we have had a great presentation on the Ayushman Bharat PMJ scheme. This type 2 is more of a multi-sectoral approach, so non-health actors also have a great play in this. And then, overall, if you see type 2 innovation, they underscore a shift towards cost-effective interventions that target the early stages of NCD development and promote intersectoral collaborations. Now, type 3, which is the integrated and hybrid approach, it integrates multiple financing functions. So resource generation, pooling, strategic purchasing, sustainable financing models, they are the most, I would say, evolved in terms of their outlook and more impact-based. In terms of private sector contribution, or PPP is one significant facet of type 3 innovation, wherein you could look at either through the expansion of insurance coverage for NCD, or you could look at public-private partnership to promote cutting-edge NCD research or support infrastructural investments in hospitals and diagnostic tools. Now, CSRs or earmarked taxes for NCDs, impact bonds are also examples that can be classified as a type 3 innovation. In a crux, if I have to summarize, I would say type 3 innovations combine resource mobilization with strategic pooling and deployment. They show the greatest potential by creating a dynamic financing ecosystem that not only secures sustainable funding for NCD prevention and care, but it also aligns the spending with broader health system goals. It supports a more equitable and effective health outcomes. Now, with these and with many more examples that have been listed in the working paper, and I'm referring to it again because I'm very keen to share when it comes out, we propose a few recommendations. We divide them under short-term, mid-term, and long-term policy actions that can be taken to effectively leverage the opportunities within innovative financing for leapfrogging the gaps in NCD care. In the immediate term, of course, the existing solutions that we have, we can scale up those, we can earmark revenues for NCD, then we can pilot and scale certain innovative models. As a transition to a long-term policy, there is a need to adopt strategic purchasing model, incentivizing the investments in prevention and primary care, and improving intersectoral collaborations and public-private partnerships. And very important point is to strengthen domestic funding, because in the long term, you need to build on it and leverage international support also. Along with that, for long-term gains in NCD continuum of care, you need to promote an integrated financing model, strengthen the governance and accountability, invest in capacity building and institutional strengthening, and enhance the policy coherence and multi-sectoral strategies. So this is a snapshot of the document and all the authors that have contributed with support from Asian Development Bank. Thank you very much.
Thank you very much, Dr. Priyanka. And as we mentioned, so the paper will be scheduled to publish in June, and we'll make that available both on the ADB website, but also linked with the Step Asia page for the seminar as well. Last but not least, the next presentation will be focusing a very important population subgroup now in the era of aging. So in this session, we are very honored to have Dr. Sumon Kwong, who is a professor and a former dean of the School of Public Health in the Seoul National University. So Professor Kwon has had over 30 years of experience of the universal health coverage, but also in the health finance, aging, and long-term care. So he's a founding director of the World Health Organization on Collaborative Center on Health System and Financing, and also used to be our chief health sector here at the ADB. In addition to his extensive academic experience. Professor Kwon, we look forward to your presentation. Thank you.
Okay,
thanks a lot for inviting me. Let me share my PPT. Can you see my PPT? Good. Okay, so before I begin, actually, my presentation covers something a bit different from the previous ones because I will talk about or sensitize the participant with the issue of aging and elderly care, sometimes called long-term care or social care. Before I begin, it seems to me that I've also worked on these NCD issues, but something we can further examine and discussion is the area of medicines coverage, because for NCD issues, we can never work properly without covering the medicines or pharmaceuticals. So we should, I hope there is a good opportunity to talk about those NCD and access to medicines issues in the future. Okay, my talk today is about this. This is WHO, and with aging and with like mid-age and toward aging, when you have a high and stable capacity, our goal is to prevent chronic conditions. And then in the stage of declining capacity, it slightly changes. So in terms of healthcare, we want to reverse or slow the declines in capacity, and at the final stage where the significant loss of capacity, or functional and intrinsic capacity, we want to manage advanced chronic conditions. But at certain point of time, for example, at this stage of declining capacity, we need a long-term care, not just healthcare, but also long-term care. And there's a lot of research showing that there is a virtuous circle or vicious circle between healthcare and long-term care. If you have a good healthcare, we can reduce the need for long-term care. But at the same time, if you have a good long-term care, we can reduce the need for healthcare for all the people. For example, long-term care can prevent the falls. And then the falls for all the people is one of the most important factors contributing the huge need for healthcare. So we should not forget that with population aging, we should also pay attention to this long-term care. So what is long-term care? Basically, it's a services that we need to provide for those who have problems in the both like a physical or cognitive disability. So they need help for a long time, like more than six months. And so they need help in the activities of daily living, or sometimes with instrumental activities of daily living, so ADL or IDL. And this is a very personal care, and is sometimes combined with the basic medical services, especially nursing, yes. But most of this long-term care, it is not provided by health professional. It can be provided by family members. That is called a informal care. So that is a very unique aspect. So long-term care is more like a social care component, not necessarily that health care. So the context, there is an increasing demand for long-term care because definitely we are facing a population aging, but population aging or the speed of population aging is different in different countries. And also, depending on the capacity of older people, like a health and functional capacity, disability of older people can be different in different contexts. And also, it also depends on a fiscal capacity to pay off older people. Like if you have a good pension system, good savings, or labor participation. So labor participation and healthcare and long-term care, they're all interrelated. If you have a good participation, you can have better health and better, functional status. Or if you are healthy, you can more actively participation in labor. Family structure, and especially living alone, is a major risk factor in terms of the need for long-term care. And editorial caregiving. When I have a policy dialogue with some of those countries or MOH and Ministry of Finance or people in Asian countries, their first response is that, well, we have a good family value system. So family members will take care of our older people to fulfill their care needs? Maybe or maybe not. Because that type of attitude towards caregiving for our parents and old parents is rapidly changing. And there are a lot of issues of this informal caregiving, whether the quality of informal care is adequate, good, or there are also a lot of gender issues in this long-term care. Because in the case of informal care, it is mainly the women who are suffering or bearing the big burden of long-term care. So in terms of the need for long-term care financing, because in most cases, market for the private insurance for long-term care is very weak because people underestimate the risk of this long-term care need. And in terms of efficiency perspective, lack of good long-term care system can result in social admissions in acute care hospitals. So they can freeze the beds in acute care hospital. So if you have a good long-term care system, we can reduce these social admissions and increase the efficiency of the healthcare system. And informal care, like family caregiving, as I mentioned, many people say, well, we can provide informal care. But there are a lot of evidence showing that the informal care reduced the labor force participation, especially for the women. And is this informal care good enough? Is it high quality? I mean, the older people may not be satisfied with the care provided by their informal providers. And also the burden on the informal caregiver, as I mentioned, especially on the women, that can be tremendous. So some countries, many high-income countries in Europe and in Asian countries like Australia, New Zealand, Japan, Korea, and China is almost ready after a series of pilot studies to implement this long-term care financing. Well, it's similarly to healthcare financing. This is the pillars of resource generation, resource pooling, and purchasing. And as I mentioned, private insurance is still very limited. So mainly so far, public financing is very important. And different funding options. For example, we can extend the existing health insurance benefits to cover some part of long-term care. Or in terms of the tax-based financing, we can allocate new budget line for long-term care. Or we can have a combination, for example, health insurance for more institutionalized care for severe cases, whereas you can use the budget for home-based care or community-based care. And one of the major differences between universal health coverage and maybe universal care coverage is that in long-term care, in many countries, they need a targeting. So not for everybody who needs, but maybe we can target the long-term care financing for more severe cases, or target people with the less capacity to pay, or target those who are more kind of old, like over 70, over 75 years old. So there's some difference between the healthcare financing and long-term care financing. And also it's very important point is that most long-term care financing has a needs assessment mechanism. So, healthcare, as you know, if person feels sick, they initiate the healthcare utilization. But in the case of long-term care financing, they should first apply for a needs assessment. And then only when they pass the needs assessment, they become eligible. And some countries, they can further consider a income, like a means capacity to pay, and target those who are poor. And in terms of service packages, again, it's a benefit package decisions. It may cover facility-based care. It may cover home-based care or some respite care. We need a priority setting. And you can only have service benefits like in kind, or you can have vouchers, or you can have cash benefits. So when all the people get cash benefits, they can use this cash to their informal caregivers, for example. And a bit similar to capitation, we can give some block grants to service providers. And the service providers are responsible to provide or fulfill the care need who are enrolled under these service providers. But there's a path dependency between healthcare financing and long-term care financing, because countries like Sweden, Australia, when they have a tax-based financing for healthcare, they also tend to adopt a tax-based financing for long-term care. And in the case of insurance-based approach, like Germany, Korea, and Japan, they have a bit like a health insurance, equally similarly long-term care insurance. And in order to save administrative cost, the insurance agency for healthcare is the same as the insurance agency for long-term care. So same agency, but different pockets. Okay. But also, as I mentioned earlier, there's some difference in terms of a generosity of benefits and eligibility targeting, or even a bit copayment in long-term care insurance seems to be higher than the copayment under the health insurance system. Governance, as we all know, governance is the key. So roles and responsibilities of Ministry of Health, Ministry of Social Affairs, Ministry of Finance, local government. But this is actually one of the key challenges in Asia, because in most countries, with the exception of Korea and Japan, Ministry of Health is separate from the Ministry of Social Welfare. And this long-term care falls in the boundary between health and social care. So coordination between Ministry of Health and Ministry of Social Protection or Social Welfare is very important. And also, there's an issue of centralization versus decentralization. And also, in many countries, local governments provide community-based social welfare services. So how to coordinate this long-term care and the community or local government level welfare services is very important. And also another key issue in the governance is that whether this long-term care financing should be separate from healthcare financing or not. You know, pros and cons. If long-term care financing is combined with healthcare financing, we are worried about a medicalization. Okay, so long-term care is dominated by medical profession, then we suffer from funding issues because cost will be higher. So like Japan, Korea, Germany, we have a long-term care financing separate from healthcare financing. But in the separation case, we suffer from a potential coordination problems between healthcare and long-term care. So this is the issue. We need a good coordination between healthcare and long-term care because we want to have a healthy aging or aging in place. And digital technology can play some role for the person-centered, interconnected, universal UHC. But still, the coordination between healthcare and long-term care face many challenges. And there are many interest groups like GPs, specialists, hospitals, long-term care facilities, home-based providers, or social service providers. So the huge political economy issues. And even in this case, I think the role of a primary healthcare or role of primary care providers is very important in improving the coordination across different levels of healthcare and long-term care. These are the kind of performance measures, potentially performance measures for long-term care financing, like coverage and financial protection, and then how many people are covered, catastrophic long-term care expenditure. But a very important measure of performance is unmet need. Because when there's no good long-term care system, then huge social cost of suffering all the people because they have a need, but their need is not fulfilled because there's no long-term care financing, long-term care system. Expenditure side, and also very important dimension of performance is quality. It's a quality of life, burden on family, person-centeredness, or coordination between healthcare and long-term care. And also equity in payment utilization and happiness, quality of life is another very important dimensions of performance. So I know that for some countries, you may think this is a bit too early, but trust me, we need to do something. We need to start preparing for this huge demand for long-term care. And as I mentioned, there's a clear relationship between good long-term care, good healthcare. We should have a virtuous circle between healthcare system and long-term care system. Thank you.
Thank you very much, Professor Kong. And this is a really a great insight and also overview of how the long-term care system. We also well know, as you say, that the countries are aging differently, and hence they also have a different resources that they have to manage. So thank you very much for the insight. Last but not least, I think we wanted to have a bit of a commentary on, what we've seen so far is going to be difficult to do the summary. But what we might do is we will ask our colleague, health specialist Blair. She has been focusing on the private sector, the healthcare, and she'll be able to bring some perspective on the presentation. Thank you, Blair. Please go ahead.
Thank you. So thanks a lot for the presentations today, really interesting. Maybe I just want to spend the time very quickly.
Hello, sorry, Blair, we can't hear you. We can't hear you. Still, we can't hear you.
We can, right? We can.
Yeah, we can't hear you still. Maybe there's a problem with your headset.
Is it working?
Yeah, still can't hear you. Can you try to remove it? And just use.
Is it working?
Yeah, better. Yeah.
Is it working? Hello. Is it working? Hello.
It's working, but you're echo.
Hello.
There's some echo.
Is it working?
Better now. Good.
It's working, right?
Yeah.
Okay, great. Yeah, let me just take off. Apologies. Yeah, so thanks a lot for the presentation. I want to keep this really short and leave the time to some burning questions to our audience. So actually, there's just one point I wanted to share when it comes to the innovative financing that Dr. Pajaj discussed when it comes to health equity. Some of the type 3 innovations may theoretically target underserved populations and NCDs, possible from nonprofits, but for those that involve private sector like impact bonds and PPPs, the profit motivation and the need for business viability may lead to exclusion of the poorest. So that comes to the question in our Q&A box on how does the National Health Insurance Scheme can be designed to ensure equitable access to NCDs care across different regions and socio-economic strata. And also, how do you deal with migrants specifically, which also can be categorized under the bucket of equity? May I pass the time to maybe Dr. Aurora and Mr. Ruby to quickly address this question on equity? And Dr. Pajaj, yeah.
So for me, so please can you repeat the question? I was stuck with something else. Sorry.
Yeah, so the question is mainly about health equity. How does National Health Insurance Scheme or other kind of innovative financing can ensure equitable access to NCDs across different regions and socio-economic strata, including migrants, which also comes to equity.
Okay, thank you for the question. Yeah, we have been kind of trying to cater all the population which is there in India, and about the migrant people. we are not right now catering, but yes, the workers which are in the state-wise migrant workers which are there, they are going to the other states. They get the portability feature, which is one of the main feature of our scheme, and it allows all the migrants from different states to get treatment in other states, and the cards are being valid in all the hospitals which are there in the scheme. And interstate portability has given a lot of relief to people. Nearly 1.5 million people have been treated across different states but through this portability feature. And we are trying to give the treatment to all the poor and vulnerable people who are there, and trying to increase that availability for healthcare to these all kind of people in all states. Thank you.
Mr. Arif, would you like to add quickly when it comes to how to manage the equity bit in national health insurance?
Oh, okay. Sorry. Thank you, Ms. Blair. For the first question, maybe I think this is about the equitable access to NCD. And yeah, of course, in Indonesia, especially, there's a geographical issue. So some of our points on that to address the equitable access is, the first one is the collaboration between the stakeholder, especially the Ministry of Health. And we do some collaboration in how to distribute the medicine, the drugs, and also, of course, the doctors into the rural area and most of in Indonesian part. So the collaboration is very important. And also we have developed some innovation. In Indonesia, we have what it called a floating hospital. So it's mobile hospital. So the hospital that conduct in a big ship, and it moves in time. So we collaborate with them. We have a contract with this floating hospital. So it's one of the effort to increase the access for the area that the health care facility is very rare. And also we assure the coverage for all of the people, especially the poor. So in Indonesia, from our total members, so the 60% of our total member is the poor. So it's more than a half our member is subsidized by government, and that is, I think, the how we addressing the socioeconomic strata. Yeah, I think, is that for the first question? Or
yes. Thank you. I think we're running out of time. Thank you very much for all the different speakers in today's presentation. I think we will wrap up now. Thank you very much for your participation.
Thank you.
Thank you.
Thank you for the panel. I just want we just have one word from the organizer that please keep an eye on the website. That's where we will post all the information and also the slides as well as the video as well. We will have the workshop the working paper materials available, but also we know that there's several questions that we were not able to address, so we might have that available as well. I think that's all from our side. Thank you very much, everyone, and have a good day. Thanks very much. Bye-bye.
Thank you, everyone.
Thank you. Bye.
Have a good day.
Thank you. Bye-bye.
Have a good day. Bye-bye.
Bye.